Hello, everybody at the OCAD group. My name is Jaron Berkowitz, and this is Mr. David Stubbs.
Hello.
We're talking to you today from Oxford University Hospitals Trust from the UK, talking to our international friends. We're honored today to hear a talk on Ilizarov, the Ilizarov method and surgical principles from Mr. David Stubbs, who's a limb reconstruction surgeon and here at Oxford University.
Excellent. Thank you very much. First of all, I want to say a big thank you for inviting me to give this talk. I hope I'm not going to be teaching my grandmother to suck eggs. It's a very basic talk about the principles of Ilizarov surgery, but actually it's something I found fascinating all my medical career. So you may very well be faced with a film with a picture on it, which you have absolutely no idea what's going on. I really want to just explode some of the myths and put your mind at ease. Hopefully by the end of the talk, you'll have an idea of some of the basic principles, and you will be able to see what you're looking at, and then we'll be able to make a helpful report rather than position as shown, which none of us really find all that helpful. I'm not going to be teaching you major mechanical engineering. The level of my talk is more about this kind of level, how we would teach someone to build a carnage set. First of all, I want to introduce this gentleman who's unfortunately no longer with us, but his name was Gavril Abramovich Ilizarov, who was born in Russia, and he must have done something very wrong to upset his seniors, because after qualifying he was posted to Kurgan, which is an industrial city right the far side of Siberia. This was in the 1950s, where there was no antibiotics. There was minimal anesthesia, no access to plastic surgery, and yet there were numerous industrial injuries which were forced upon him to treat. So he devised a method to stabilize complex fractures, open fractures, with minimal anesthesia. It was usually morphine and alcohol that they used to sedate their patients, but with simple debridement of the wound, he could pass fine wires, which initially were bicycle spokes, through the skin, through the bone, and out the other side, and then stabilize these on metal rings to create a cage around the leg. The wires were initially very bendy, but if you tension the wires, the construct becomes like a tennis racket, which is very rigid, and so you can stabilize a fracture without placing any metal wear in the damaged or infected zone. The construct was so strong that it allowed early mobilization, and so it avoided the fracture disease that we saw with plaster casts that we were using in the Western world. And it also allowed for gradual correction of the fracture after the frame had been applied. So once the patient was awake and they actually got a check x-ray, because they didn't use x-rays during the operation, it was all done by eye. But if they got an x-ray, it allowed them to do a gradual correction of the fracture. And what he noticed was the more these fractures were corrected, the more callus they threw out. And the bone was stimulated according to the principles of Wolff's law, where the more force it applies with the bone, the more bone it forms. And he found you could perform regeneration or lengthening of bones. And this led him to do numerous studies on animals, using dogs and sheep, and he published extensively. But his techniques didn't come across to the UK until about the late 80s or early 90s. So the technique that he described was called distraction calotasis. And the principle was that if you perform a very low energy corticotomy, so using a chisel, are trying to avoid disturbing the medullary canal, there's a technique you can use without damaging the intramedullary artery. You can crack the bone. If you then fix the bone in a rigid state and just hold it still for 5 to 7 days, then the fracture would start to form callus. You can then distract this callus at a rate of about 1 millimeter per day whilst it's still very stretchy, and it will keep making more callus. And eventually, a fairly large defect can be replaced. So the rings that he made were very basic, and the rings that we use are still very basic. The whole of the frame is made up of rings, wires, nuts and bolts, a few rods, and if you put them on with some very basic frame building skills, you can actually do complex reconstructions. There's nothing fancy about the rings. The ones we use are made of carbon fiber, and they come in 2 halves, and we fix them together with a bolt. But there are also stainless steel versions, and some which are shaped to go around the foot, and 3/4 rings which allow a gap behind a joint to allow you to still be able to bend your knee or elbow, for instance. There's nothing very special about the wires either. The wires we use are stainless steel. The end of the wire has been hammered flat and then just cut to a point so that it drills through the bone. It really is as simple as that. Some of the wires we use have an olive on them. It's basically a blob of stainless steel halfway along. It allows you to pass the wire through the bone. When the olive comes in contact with the bone, you can use it to push against the bone or pull against the bone and get compression between oblique fragments. When the wires go in, they're very bendy. But if you tension them to between 90 and 130 kilograms, they become rigid. And at this point, you have a stable fixation of the bone. The nuts and bolts, made of stainless steel, we use them to create the rings and hold everything together. And the variety of hinges and posts allow us to mount the wires either above or below the ring without causing distortion. What you don't want to do is to pass a wire that isn't adjacent to the ring and then tension it down onto the ring, because that will bend the bone and cause distortion. So we want to mount the wire exactly where it sits in relation to the frame before we tension it. Sometimes it's not practical to pass a wire all the way through the skin and out the other side. For instance, if you're going front to back at the knee, you're going to run into the popliteal artery or vein or the nerves. And so we use half pins, which are straight pins with a threaded section. It allows us to drill a hole, pass the pin through the bone, through the cortex on the far side, and then stop. And these half pins are then mounted to the ring with nuts and bolts, and it allows us to get fixation close to joints or vital structures. The rings are connected together with rods. The rods, again, are made of stainless steel. You can buy them down at B&Q. They have M5 rods or M6 rods, and the pitch of the rod is 1 millimeter. What this means is that for each complete turn of a nut, the nut will travel down the rod by 1 millimeter. This has been engineered that way to make it simple for orthopedic surgeons so we don't get too lost. But another thing that helps us is these nuts here, which have dots on their faces. They have 4 faces, and there's like 1 dot on that face, 3 dots on this face. And so 1, 2, 3, 4, we know exactly where we are with the lengthening. 1 complete turn is 1 millimeter. So what we tend to do is do 1/4 of a turn 4 times a day, because Ilizarov found that lengthening a bone by in 4 increments creates bone much faster than doing it in once a day or 10 times a day. That's the best compromise. When we're passing wires, we have to keep an idea of the anatomy of the bone and the nerves and blood vessels that are surrounding the bone, because we don't want to skew them with our wires. But we also want to try and get as wide a spread of the wires around the ring as we can. So if you've got two wires at 90 degrees and they're tensioned firmly, you can see this bone, it can't move in either direction. However, if we've had to place our wires too close together, even though they're tensioned, because the wires are smooth, this bone can still slide along the bone. It won't have ideal fixation if that was all it was holding it. So if there's important structures such as nerves or blood vessels at the back that you want to avoid, we would normally have one wire going horizontally and a half pin front to back, which leaves us all this space around the back without anything being interfered with. If we put our rings too close together and we try and stabilize a bone, because there's a slight flexibility in the wires, this bone is still free to rotate around an imaginary hinge in the center of the bone here. But if we spread our rings out with exactly the same tension in the wires, we're going to get much less movement of the bone. So if we're trying to fix a fracture, for instance, we try and get two rings close to the fracture, two rings far away to get the most stable construct. So far, we've just looked at straight rings, but the bones aren't always straight and often have deformities that we need to correct. So we use hinges and drivers. On the Ilizarov set, the hinges come in parts. We have to assemble them first with nuts and bolts, and then we fasten them onto the rods. But you can then create a construct with two rings fastened to the bone, a hinge placed here, just under the top ring, and a driver on the side with our dice nut here. So as we turn the dice nut and lengthen this rod here, it will gradually perform the correction and straighten out the bone. So it's very important that we place the hinges in the right place. If we place the hinge directly over the center of rotation of the deformity and perform the correction, then we'll get angular correction without any translation. If, however, we put the hinge at the wrong level and we perform our correction, the bone will rotate around the hinge and it will cause translation at the fracture site. Now, sometimes you want that, so we place the hinge above or below the fracture on purpose to create a deliberate translation to correct a deformity. But other times, it can be a problem. The other way we can use hinges to our advantage is if we place the hinge off the bone, so along the same line as the center of rotation, but either on the convex or the concave side of the bone, as we perform an angular correction, it will either perform lengthening or shortening at the same time. So you can create complex deformity correction using a simple hinge as long as it's placed in the right place. You may hear frame surgeons talk about monofocal or bifocal correction techniques. So that's what I'm just going to run through now. Up to now, we've done either an angular correction or a simple lengthening. So if you're just performing compression or distraction, at one point, this would be a monofocal technique. If you've got a simple fracture that you put in a frame, and compressed it until it healed, it would be a simple compression. If you performed an osteotomy, then a lengthening, then that would be a distraction. We talked about angular correction, again, monofocal, lengthening, place the bone, and lengthen it to one side. A bifocal technique might be where if at the fracture site there had been bone loss or infection, so you had to excise some bone, but you wanted to compress the fracture to get healthy bone ends touching, that would leave overall the length of the bone short. And so once you've applied the frame to perform compression at the trauma site, you perform a separate corticotomy, either proximally or distally, where you would then re-lengthen the bone to get the bone back to the original length at the end of treatment. In actual fact, when you look at complex fractures or non-union fractures, the bone that has healed and has been treated with a bifocal technique with a lengthening as well as the compression at the site of injury, the actual healing rates are better than if you just applied compression or distraction alone. And that's mainly because the act of lengthening the bone stimulates the whole limb inflammatory process, the healing process, the blood supply to the limb actually increases by up to 6 times if you measure the blood flow through the leg, to the extent that the Russians have even used lengthening techniques to treat people with arteriopaths to heal ulcers in their leg quite successfully. Unfortunately, if you've got a bone defect which is more than 4 or 5 centimeters long, it's not always possible to perform acute compression and get the bone ends together touching straight away. And in those cases, we tend to use bone transport, where the overall length of the bone stays the same. The defect might be debrided and left empty, but then the proximal corticosteum is made here, and the middle segment is transported through the soft tissues until it docks at the docking site, so like an elevator going down through an elevator shaft of the soft tissues, and that's called a bone transport. And the difference with compression distraction and bone transport is that in the transport, the overall length of the bone stays the same throughout treatment. Up to now, all the deformities we've looked at have been monoplanar, so a simple angular correction or lengthening or shortening, but not all deformities are like that. Some of them involve translations or rotations, and whilst we can correct some translations by hinge replacement, as we looked at earlier, some of them are a bit more complicated. And so in, well, probably about 15 years ago, there's Charlie Taylor, a orthopedic surgeon in America, his brother was a mathematician, came up with the hexapod system, whereby a series of zigzag rods, 6 zigzag rods, are used to correct 2 rings. But using complex mathematical formulas, you can actually perform corrections in 3D, basically lengthening, translation, rotation. As long as you tell the computer the length of the rods and where the bone is, it can basically perform a correction for you. It's very powerful, but it's also a little bit finicky, and it's easy to make mistakes. So this is an example of where we might use a simple, straightforward monofocal technique of lengthening. In this case, this is a tribal leader from Papua New Guinea who had one leg longer than the other from an injury as a child. And in Papua New Guinea, actually, height is, amongst the pygmies, is something to be valued. So rather than let us shorten his long leg to correct his leg length discrepancy, he desperately didn't want to be any shorter, so we opted to lengthen his short leg. And this standing film, you can see the pelvis is tilted by 3 or 4 centimeters, standing on a block of 3 or 4 centimeters. So it's a significant deformity. We elected to straighten this using lengthening of both the tibia and the femur. So with the femur, we used a monolateral fixator. With the tibia, we used a ring fixator. These were applied with good alignment onto the leg. The tibia was cracked. In the proximal third, femur, you can see the crack. And this is about halfway through treatment, where you can see the femur is lengthened by 3 or 4 centimeters. It's a bit harder to see the tibia on that view. This is the final result of the femur, where the new bone that's formed in the gap, the new bone in the tibia, it's got a little bit of maturing to go, but in 2 or 3 years, you won't actually be able to see the joint. But he was absolutely delighted. This is perhaps a more complicated problem. As a young man, motorcycle injury, proximal tibial fracture that was initially treated with an external fixator, but the treating team took the fixator off too early and didn't brace his knee. And 3 months later, this was the position that the knee set in. He was about 3 centimeters short. He was in severe varus, and he was rotated by about 45 degrees. He was really walking like a crab when he came into the room. But you can see there's already callus. These these bony fragments are well fixed. Surprisingly, despite the appearance of the knee joint, he had a really good range of motion in the knee. So it's felt this was worth correcting to save the knee, appreciating that we might need knee replacement at some stage in the future. So multiplanar deformity, rotation, lengthening, angulation, all required. So we opted to use a spatial frame, and this was the frame after it had been applied, finalized through the proximal segment. So the distal segment is in alignment with the distal tibia, proximal ring in line with the knee. Then you just put the ring on so that it matches the deformity, and tell the computer what numbers the rods say and where you want it to end up. And this is him after rough correction. You can see in the fracture gap, there is some early callus forming, but it's still very soft. And this allows you to make fine adjustments towards the end of treatment. The patient will tell you when they feel right. They say, yep, my leg feels right, and now my knee feels in alignment. And you can get your long leg films and check the alignment and make fine corrections before you leave it to set. Now, generally, the bones take about twice as long to consolidate as you've been lengthening for. So even though this lengthening is only about 30 millimeters, the framing would need to be in place for 3 or 4 times that, so it would be 3 or 4 months. However, this is the before and after pictures. When the bones consolidated, you can see the alignment of the limb is very good. And to my knowledge, he hasn't been back for his knee replacement yet, and this was many years ago. One of the most impressive places where you see frames used is where there's been bone loss. This is an example of a 15-year-old young girl who presented with a tumor in the bone. We've probably all named it already, but this was an adamantinoma, which you will know is very locally aggressive and probably without fracture, but they rarely metastasize. So if it can be completely excised, then excision is likely to be curative. However, she's been told that there's a chance she could lose her leg, she might need an amputation, and she desperately didn't want any surgery to her other leg. She thought that was going to be her only good leg. So the option of using a free fibula to replace the missing bone wasn't particularly attractive to her. And at the age of 15, if we'd have replaced this segment with a metal implant, we can envisage it's going to have to be monitored throughout her life to look for signs of loosening, fatigue, fracture of the implant, etc. So we elected to replace this with bone transport technique. Here on the left, you can, well, both of you show the actual length that was excised in order to get clear margins. It was about 15 centimeters. Note that the frame has been applied perfectly aligned to the bone, the top ring parallel to the knee joint, the bottom ring parallel to the ankle joint. All the rods are parallel to the remaining bone. So if we crack the bone here and move the middle ring down these parallel rods, this bit should end up here if we've done it right. So here we can see it happening. This is after about 20 days. The middle segment started to move down the elevator shaft. About 30 days on the right. Midway through treatment, you can see in the gap, the distraction gap, that some wispy streaks of new bone forming. And they are the full width of the segment, and looking very healthy. The bone in the center, which is where the actual lengthening, is less ossified than that at the ends. And here on the right, we can see it's nearly docked. The lengthened bone is still looking a little bit streaky, although if we look very carefully, we can see in places it's reformed a cortex. So there's a cortex and a medulla in the reformed bone. Here, there's no cortex. And when we're trying to assess whether the frame has been on long enough and it's strong enough to take a bit of weight or to go in a brace, we look to see cortication on at least 3 sides. So if we've got cortication on 2 sides on the AP view and 1 side on the lateral view, that's enough. Obviously, ideally 4 sides, but we look for cortication on 3 cortices on 2 views. And this was the final result. It's about 6 months after the frame came off, and you can see the bone has reformed. It's got a nice cortex and a medulla. And in actual fact, if you were to take segments through this bone and look at it under a microscope, the histologists would not be able to tell the difference between that and a normal bone. So it took a long time. It was 15 centimeters. That's 150 days of lengthening, plus at least twice that length again of consolidation. She was in the frame for over a year, but she has now a bone that is her own bone, perfect alignment, perfect length, and it's going to last her for the rest of her life without any further operations. So in many cases, it's worthwhile. You don't have to go forwards. This is a case of transport, another bone tumor. There wasn't enough bone proximally to lengthen from above, so the corticotomy was performed distally, and this distal segment was transported backwards, and you can see the result was the same. As long as you're careful to perform the corticotomy without causing too much damage or stripping of the soft tissues of the segment, you can get away with transporting a segment that's only 2 centimeters long, and it will keep enough blood supply in its periosteal attachment and any endosteal supply to get a good lengthening. So there you are, retrograde transport. But again, even longer segment, choosing the frame for even longer. So over the years, various techniques have been discussed to try and shorten the amount of time someone spends in the frame. Here, we're lengthening over a nail. So nails have been placed down the intramedullary canal, and the bone has been cracked, corticotomy performed here. An external fixator has been applied, and then the lengthening is gradually performed over a millimeter per day. But then as soon as you finish lengthening, you can lock the nail with a day case procedure and take the frame off, and then the nail on the inside is performing the job of the frame whilst it consolidates. So in actual fact, the frame was only in place here for about 30 or 40 days, and then it was locked. And once the nail is locked, actually this person can be fully weight bearing, although it is obviously going to be uncomfortable and a bit tight until the bone is consolidated and they've stretched the muscles out with a lot of physio. So much shorter frame time, but the same result. Another way of shortening the frame time is to perform bifocal lengthening. So rather than just lengthening in one spot, the bone can be cracked in 2 spots. And then in this example here, we have the distal fragment is being pulled through the tissues by this cable at 2 millimeters per day, and the middle segment at 1 millimeter per day. If you think about it, therefore each gap is opening at 1 millimeter per day. So you can perform lengthening at twice the speed. This can also be combined with a nail, so you can have a lengthening with 2 sides with a nail in place. So once the distal fragment is docked at the bottom, you can lock it in place with a screw and then take the frame off. So it's trying to do the best of both worlds. It wasn't possible to nail initially in this young girl because the distal segment was so badly damaged and infected, requiring free flap, that the nail couldn't be put into the affected tissues until it would settle down for them. But she may get a frame soon after removing. She made the nail soon after removing the frame to allow the frame to come off sooner. So things don't always go according to plan, and some of the things which we rely on you guys to watch out for on the X-rays, if we miss them in a busy clinic, are listed here. People are doing lengthening, particularly in children, with congenital deformities, where we're often wanting to lengthen the segments by more than 10 or 15%, which is more or less the maximum you can do in an adult. And you have to watch because the muscles and tendons don't lengthen at the same rate as the bone. And so whenever we're taking an X-ray of the bone that's being lengthened, it's vitally important to include the joint above and below in both AP and lateral, because you may spot subluxation of the hip or the knee joint. Clinically, this would normally be apparent by the patient not able to get their leg out fully straight when they're doing their physiotherapy. So we will be watching out for any patient who can't get out the leg fully straight. And if we get more than 10 or 15 degrees of fixed flexion deformity, we would normally stop the lengthening, just do intensive physio for a few weeks to try and stretch the knee out, and then carry on with the lengthening if that's possible. They can't stretch the knee out with physio. Sometimes you need to extend the frame beyond the joint and use the frame to strengthen the knee and straighten the knee out using an angular correction technique. Similarly, it's important to watch out for the X-rays when the leg is shifting into varus or valgus. This is much more common with monolateral fixators than it is with ring fixators, but it's something to watch out for. Pin breakage is then easy to spot on an X-ray. The patient might also complain that they felt a sudden ping or twang in their leg, and that might be evident on the X-ray. Thankfully, the inherent nature of frames is there's redundancy in the frame. Usually there's 2 or 3 wires on each level, and so the odd breakage of 1 wire or 1/2 pin, particularly if it's toward the end of treatment, where generally we're trying to encourage more force to go through the bone to stimulate the bone to get stronger, is not usually an issue. But pins or wires can be replaced if we need to. Pin infection is relatively common. Probably 30% of people will suffer a pin infection at some stage during treatment of the frame, particularly if it's been on for several months. Most pins will settle down with a short course of antibiotics or cleaning them more regularly. But if we start to see this on the X-ray with loosening, with periosteal reaction, and these bottom pins also appear to be sliding through the bone, then that's a sign that this is becoming unstable, and some other form of fixation probably then be required. Even after we've taken the pins out, sometimes the problem hasn't gone away. When the wires are passed through the bone, they are drilled through, and if the bone is sclerotic, the wires can get quite hot, so they may burn the bone and cause some necrosis. If this pin then gets infected, when you get lysis around the burnt bit of bone, you get this classical appearance of a ring of dead bone with a lytic zone around it, which we call a ring sequestrum. These can be spat out by the body several months after the frame came off, or occasionally we have to take them out. Surgical procedure, as was the case with this one. The reason this wire probably formed a ring sequestrum is that this is a lateral X-ray, and you can see the wire is going directly through the anterior cortex of the tibia, which is actually probably one of the densest bits of bone in the body. So we try and avoid passing wires directly through the anterior cortex. And here on the CT scan, you can see the ring in profile here, where the wire was, and then the periosteal reaction around it. And this ended up needing over drilling and scraping out before it settled down. Refracture can happen once the frame comes off. When we've had a bone, if it's well reduced, it's actually sometimes very difficult to assess whether the fracture is healed or not. Here it looks like the bone is strong enough to take the frame off. There's healthy callus on each side of the fracture. The alignment was good, and when he walked around for a day or two, the frame in the loosened position, it was pain-free. But unfortunately, 2 weeks later, the bone refractured and had to be realigned. Actually, because at the time in the frame, the original indication for having a frame, the infection or ulcer or whatever it might have been, had then healed, and so it's possible to fix that with a more standard technique of a nail, allow it to get walking on it straight away. And actually, these usually do that very quickly once they're stabilized. Occasionally, the regenerate isn't quite as good as we hoped for. On the left here, we can see lovely regenerate. It's at least the width of the segment that's being lengthened. There are no gaps in it, and this is no worries at all. Whereas same patient and the segment a little lower down, whilst it looks okay on the AP view, when you look from the side, we can see a large cyst in the in the regenerate, which is just taking it much longer to fill in. Now, some people routine ultrasound their regenerate gaps to look for cysts, and if they see cysts, they will aspirate bone marrow and inject it into these cysts to try and encourage them to fill in quicker. Actually, we found if we just wait, if we just get the patients walking on it as much as possible, they generally fill in, or at least they'll fill in around about enough for not to be worried. I've never seen a problem with one later to come on. What's a bit more difficult to predict is docking site problems. This was the patient we saw earlier that had the bifocal lengthening, and as the tibia came down and docked into the ankle, on the lateral view, it looked really good because of the dished shape of the bone, but you can just see behind this ring that it may not all be hunky-dory. And on a CT scan, we can see quite clearly that there's no bridging between the two fragments. And this is one of the hardest parts of frame surgery, to decide when the frame is going to be ready to come off, and whether or not this is going to heal by itself, or whether we need to do something to stimulate it. We have a number of things we can do to stimulate docking sites. The most potent stimulation to forming bone is always distraction. But you can't distract it if it's really too wobbly. You need a modicum of stiffness to be able to apply enough force to stimulate bone to form. So cycling compression with distraction is often enough to cause a bit of inflammation and scarring in the more dormant area, so that when you then start to distract it, you can form bone. Occasionally, you have to go in and put some bone graft from somewhere else in the body, or if you're just getting extremely bored, then taking the frame off, nail down, the act of reaming the center of the canal creates lots of auto bone graft, and putting a nail down holds it still, usually stimulates it to heal quite quickly. So in summary, it's a very simple concept with basic components, but with very careful planning and close supervision. It's very versatile and very effective in cases, and certainly more useful than some other techniques.
David, that was very informative. This is Hillary. I just have a couple of questions. You showed us all examples of lower extremities. Do you do this in the upper limbs?
Absolutely, we do. One of the commonest reasons for doing lengthening is that people have limbs which are different lengths. So in the leg, that's very important, because if you have one leg longer than the other, it causes a limp. In the upper limb, if you've got a small amount of bone loss, you can shorten the humerus, for instance, by several centimeters, and apart from your tailor, nobody would know the difference. And so there's less indication for doing lengthening techniques in the upper limb than there is in the lower limb. But if there's large chunks of bone loss or angular deformities, or bone loss, for instance, radius or the ulna, then we do ring fixators and monolateral fixators to do lengthening there as well.
My other question is, you mentioned different techniques for speeding or improving bone growth, and it sounds like you mostly rely on these mechanical tricks of compression and distraction. But do you ever use, bone stimulators or morphogenetic protein, or things that they use to grow bone, stimulate bone in other locations?
We've tried all of them.
Yeah.
There are people that use bisphosphonates to try and alter the remodeling of bone, growth hormones, thyroid hormones, BMP 1, 7, 2, and none of them seem to be as effective or as reliable as the mechanical stimulation of Wolff's law. Effectively, if you've got the mechanics right and the biology right, so you've made sure that all the bone that is there is alive, the right mechanical situation, then if it's not forming bone, it's probably something you're doing wrong or have missed, and in which case putting in very expensive BMPs, which are several £1,000s a go, but concentrations that nobody knows what concentration they should be given in, and there have been numerous reports, and we've seen it, of ectopic bone being formed by BMPs, which is always a worry, because when we put these stimulating agents in, how do we switch them off again? So we have moved away from it, and it must be 5 years since we've used any BMPs in a reconstruction patient here in Oxford.
Interesting. Any other questions?
Hi, David. This is Tudor Hughes. I was very lucky. Back in the early 90s, I worked with John Fixon and Nicola Mafuli at Great Ormond Street, and we did some work using ultrasound to try to monitor the limb lengthening to decrease the number of X-rays that the children needed. I can't say it ever really caught on, but it seemed like a good idea at the time. One of the things that you said that interested me, you said that distraction was a greater incentive for bone formation than compression. And that seemed to go against Wolff's law, because I would have thought Wolff's law was saying that compression and weight bearing reformed the bone as to where it was needed. So that surprised me.
It is interesting, but Wolff actually didn't specify which direction the forces were applied. He just said that the bone is formed in response to the forces that pass through it. Yeah, we all know that bone, once it's there, is very responsive to the forces that are going through it, and it's one of the ways that external fixators are very helpful, in that because they're so strong, and they allow you to get the patient weight bearing as quick as possible. We do see, if we've got floating segments for the transport, for instance, it's not having any the daily repetitive weight bearing force going through it. It forms bone much slower than once the bone ends are touched, such that they're being then stimulated by the slight springy compression forces that the frame allows. Because you can make a frame too stiff. If you make it too stiff, then again it forms bone less quickly than if it's just the right springiness. A lot of these things have been found by trial and error rather than using fancy strain gauges, but yeah, it is very interesting that the actual direction of the force doesn't really seem to matter as long as there are repetitive forces going through the bone.
And I remember an interesting story about Ilizarov, that I think he came to something like an American Academy of Orthopedic Surgeons meeting back in the 80s, and there were people there presenting their 1 or 2 cases of external fixator limb lengthening. And then he comes along and presents something like his experience with 1,000 cases, and it just blew away the conference. And that's why it just took off so quickly, that he had so much more experience than anybody else at that stage.
The guy was a visionary. Yeah, unfortunately I never had a chance to go to Kurgan during my training. I had 3 kids, but I would have loved to have gone. The hospital that is out there in his name. It's over 1,000 beds, and it's purely people having brains.
Yes.
Patients stay there throughout their treatment, having intensive physiotherapy, and the results they get are better than we can achieve over here. But we try to persuade a patient to stay in hospital for 3 months for physio.
Have you had any experience with these intramedullary nails, which have sort of had their own little battery-operated motor inside them and can do the leg lengthening from inside rather than outside?
We have a little experience of it here. I know all about them, and I've seen all the complications, and we've been referred a few complications to put right. But in principle, they are probably the future. But at the moment, the mechanics and the strength of the devices isn't quite there, and failure rate is a problem. The early devices that were powered by springs rather than motors had a habit of running away with you would perform, for instance, 2 inches of lengthening in 2 days, which isn't very good for bone formation. And the newer ones, because of the complex mechanics and machinery in there, they're not quite strong enough to take the full weight, and so there have been a few breakages and a few failures. But I'm told the newer designs are much sturdier, and at the moment we prefer something a bit more reliable, like lengthening over a nail, where we know exactly what's going on. We can stop lengthening if we want. We can restart lengthening. We can take the frame off when it's done.
Yeah,
it does have a slightly higher risk of infection. If you get a pin infection in the nail in place, then that is a risk. At the moment, it's also significantly cheaper than the electronic ones. So I think it is the future. I think we will see more of them. But at the moment, the technology is not quite caught up with the idea.
Yes, I remember a time before they had the motorized version where you would do something like you would rotate the leg distally on the proximal, and that would click it out the 1/4 millimeter, and you do that the 4 times per day.
Exactly. Yeah. So they had a habit of running away. They had a really powerful spring inside of them, and as you say, a ratchet mechanism that would you basically perform an internal or external rotation of the tibia in relation to the thigh, and it would release the catch. But some of them had a bit of a hair trigger, or they just jam up completely.
And then I had another question. Sorry for being so many questions.
Sure.
When you're doing the bone transport, how do you exclude the soft tissues that are already in the gap from getting crushed or catching on the bone fragment, or is they just automatically just move out of the way?
They do seem to automatically just move out of the way. That when you've taken out a bone, either it's been done leaving some periosteum behind, or it initially forms a canal that's filled with hematoma, which then solidifies, and it during the time that the bone is coming down, it rarely gets more than kind of jellyish or a very soft kind of loose connective tissue in consistency. I think if you were leaving it for months and months and months, then you could run into difficulties with. The problem more is the wires which cut through the skin as you go down, which is why we've tried using cables for the longer on the inside of the bone for the longer transports. But the wires, if you don't have too many in the segment that's being transported, they will actually cut their way through the skin, and the kind of the wire track will heal up behind it as it goes. We've seen fewer problems than you expect.
Thank you.
Thank you.
Well, if there aren't any other questions,
I had one question, but I'm sitting next to David, so I didn't want to.
okay, so go ahead.
Which was about sort of how you deal with adolescence and puberty and growth spurts. Because obviously they've got natural growth of bone, which is going to be more at the distal aspects of the joints, at the physes. And then you're also doing bone transport, and how do you compensate for that? Is it just lots of remeasuring the limb lengths and trying to stay symmetrical?
So yes, you've probably seen the Anderson Green growth charts, and the pediatric limb reconstruction surgeons have these imprinted in their mind, and there's the various Paley multiplier techniques. You can predict which growth plates are going to grow by how much at which stage during puberty, and the percentage is pretty much always directly proportional to their position on the centile chart. So you can predict fairly accurately within about 5 millimeters how much one leg is going to grow in relation to the other. And so in order to obtain equal leg length at adulthood, it's usually a combination of planning an epiphysiodesis to slow down the growth of the longer leg, combined with a lengthening of the shorter leg at the correct moment in time without damaging the growth plates any further. So it's all quite fun. Unfortunately, we don't do the children here at the orthopedic interval. That's all done in our neighbouring hospital. But we up until 10 years ago, we did all that as well in this unit. It is quite fun. But yes, you've got to be on the ball.
I'd like to thank Professor Stubbs for a very informative lecture. I learned a lot. I really like seeing radiographs for a change, and thank you.
Thank you.
Thank you.
Cheers.
Bye-bye.
Bye.